Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one-size-fits-all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Welcome to Talking Therapy. This is Marvin Goldfried together with his dear friend,
Alan Francis. Hi, Marvin.
Hi. And so, Alan, last podcast, you were talking about some of your experiences with DSM, both 3 and 4. And you mentioned in passing, and I don't know if I ever read it in something you wrote, but you indicated that the experience you had basically soured you on consensus meetings, that they really were not consensus, that there was bias. And I think this is kind of an interesting topic. I'd like to hear more about that from you.
Well, sure. The DSM-III process was a real eye-opener. It was led by a very enthusiastic, very smart, charismatic person named Bob Spitzer. And at that point, there was very little scientific evidence to back any particular contention about how the diagnostic pie should be sliced. So what Spitzer did was develop this technique. He would invite experts in the field, usually each diagnosis, usually about 5 or 10, sometimes 12 or 15 people. We'd gather in a room, usually in the New York State Psychiatric Institute where he worked. And during the morning, there would be a lot of screaming and yelling about this criteria, this diagnosis should be in, that diagnosis should be out. Then he would order in a big pastrami deli lunch, lots of pickles, and everyone would get really tired. And the afternoon discussion, Spitzer would be sitting in the morning typing like crazy. He said very little, but would be typing like crazy. And in the afternoon, he would provide a set of criteria for a diagnosis. The original DSM criteria sets were mostly first drafted by Spitzer sitting at these meetings typing like crazy. In the afternoon, everyone would be tired. The discussions would be much less animated. And usually what he had written was more or less accepted. But whoever knew him best, whoever worked at PI, whoever was most senior in the field, would continue to influence the criteria set very much. And
whoever was loudest.
Loudest, seniorist, most stubborn. I did the final draft of the personality disorders. And there was very little to stop me from changing it in various ways, because once you got to that point, there was no other meeting that determined whether things were accepted. So it was completely chaotic. It was arbitrary. It was subjective. It was, and this is the worst part, that I've worked now on DSM-III, 3R, and 4, and with thousands and thousands of experts. I've never had an expert come up to me and say, I think my diagnosis is defined too broadly. I think we may be capturing false positives. We may be mislabeling people. They always worry about their pet diagnosis being missed. They always worry about the idea that a patient won't get a diagnosis. They never worry about mislabeling. And so you can't trust experts. It's like a fox guarding a hen house to trust experts on their own diagnosis, because they'll always expand the definition so that it will be over-inclusive.
Now, I don't remember reading that amount of detail that you're telling me right now. Did you write something about your experiences, at least your pessimism about the way consensus was gotten?
Yeah, I detailed it a lot in the book, Saving Normal. I think the point I was trying to make is that you shouldn't have the American Psychiatric Association in charge of psychiatric diagnosis. You shouldn't have the experts in charge of deciding what goes into the manual, because it's inherently a conflict of interest for a professional association or for individual experts to have that much power. Some of this is financial conflict of interest, and that's been made much of, but that's much less of a problem than intellectual and emotional conflicts of interest. The financial conflicts of interest you can define, and by and large, it wasn't to me a huge problem. I did not experience the DSM-III, DSM-IV, or DSM-V process as being overly influenced by financial conflicts of interest, but all of them were terribly influenced by the enormous power of love that experts have for their pet diagnosis. And the intellectual and emotional, their careers are based on their diagnosis, and they're always pushing forward. My diagnosis should have more prominence, should be more broadly defined.
Doesn't look that way when you see it in print, does it?
Well, it's. I think the reason I was chosen for DSM-IV was that the Mel Sapshin, who was the medical director of the American Psychiatric and the person who I think selected me, was concerned about the instability of the system. The DSM-3R was very different from DSM-III, that new diagnoses were flourishing. And I think he wanted a skeptic at the helm rather than someone who would continue expanding the system. And so we set up a very different method for DSM-IV, that we said we don't want changes. DSM-3 and 3R, the idea was it's interesting and exciting to be expanding the diagnostic system. We said we don't want changes. The data will have to jump off the page. The graph will have to grab you by the throat and say, you have to make this change. And so we instituted the 3-stage process of very extensive literature reviews, of data reanalyses, and of field trials. And before any change could be made, it had to be a compelling reason. And even with that, we shot down, there were 94 suggestions for new diagnoses for DSM-IV. We accepted only 2. And those 2 made perfect sense at the time. That were bipolar 2 and Asperger's disorder, and both of them backfired and led to fad diagnoses.
But Alan, the bias was still there from 3. The bias was in the version that you were looking at and trying to revise. And what you're saying is you didn't make too much revision of something that was biased to begin with.
That's a great point. The fact that we demanded compelling evidence to change the diagnosis by adding disorders or by loosening thresholds also meant that we had to make the same requirement for changes that would have knocked out diagnoses that shouldn't have been there, that were there for biased reasons, or to heighten the thresholds that would make it more difficult for diagnosis. So I took a conservative stance that said we won't make changes, but in effect, it's exactly what you were saying. It baked into the cake all of the radical changes that had been made before.
It's kind of interesting. I had some experience in the past with consensus meetings. There was one that was sponsored by American Psychological Association and the NIMH, and it was to come up with standard outcome measures to be used in clinical trials so that there'd be consistency from one study to the other, and you could make generalizations. So we broke into small groups. So we had depression, anxiety, and personality disorders. I was in the anxiety group. And there was a handful of us. And then we would meet in plenary session. So we were discussing what should be part of the outcome measure. And people were saying, obviously, symptomatology of anxiety. And then I raised the question and I said, anxiety is also a function of the person's efficacy beliefs. And that maybe we should assess that as well when we do intervention, because it's relevant. 2 of the other people, these are therapy researchers, both of whom were psychodynamic, said, "Oh no, Marv, I don't think that's a good idea. We should deal only with the symptoms, not any of the underlying causes, because that's what the NIMH will fund. And I was blown away. I was blown away because I had the same debates in the 1960s with psychodynamic therapists, where I was saying, look, this behavior therapy produces symptom reduction. And they said, well, symptom reduction is not enough. We need to look at more. And it just dawned on me how policies can change the way we think.
Yeah, I mean, I think a modern example of this is the Supreme Court in the United States. Should 9 people appointed to such a corrupt process be able to determine the fate of the whole country? That you can't ever be sure when you have 9 people in the room, whether it's diagnostic issues or psychotherapy research issues or abortion, that those 9 people are going to represent the broadest wisdom, the least bias, the best outcomes, the relevant life experience, that you can never trust a small group of experts to have the final say. I think you need experts in decision making, but you should never give them the final say in calling the shots.
Particularly if the experts are political appointments. So the Center for Disease Control and guidelines for COVID don't necessarily follow the science. It takes into account a lot of politics and economics. And the gap between policy and science, I mean, we see it with health, we see it with guidelines for climate control. It's a major problem. And one wonders, how do other fields ever get consensus? Because they do, to some extent.
Well, it's pretty lousy in the rest of medicine. Recently, a year or so ago, the American Medical Association and the cardiologists sponsored a change in the criteria for hypertension. And through a slight change in which blood pressure was considered to be pathological, they newly included tens of millions of people. And I was at a conference when the data were presented, and the person who was most in charge of the guideline could not defend the change, that the science was very ambiguous, as it always is. In most of medicine, most of psychiatry, most of psychology, the science usually doesn't jump off the page and grab you. There's a lot of interpretation that's involved. And changing just a little bit with the threshold for high blood pressure results in tens of millions of people being treated completely differently on the basis of very little evidence with the consensus process. So I think changes should always be made with the notion that everything that can be misused will be misused. If there's a possible harmful unintended consequence, it will happen. And everything should be done with great care and not be left to the hands of the people who have the biggest stake in the decision making.
Well, even though you're talking about the difficulty of getting consensus in medicine, still there's a certain amount of consensus that you can get. For example, and I'm sure you've had this experience, and I'm sure lots of other people, you have a physical problem and you want to know more about that before going and setting up an appointment to see somebody. So you go online, and you go online to careful websites with either .edu or .org, and you look up and you see what they say about the disorder and about the treatment. And if you go to 2 or 3 and they all agree, there's some indication that there's a consensus, at least on certain kinds of things. So it's not 100% bleak. I mean,
although it's interesting, the internet's a tremendous value to patients and to us. I think the information is wonderful and so readily available, but there is so much misinformation that it's very hard to know what consensus means, because it depends a lot on where the algorithm sends you. But Marvin, I'm really interested in getting into a related and I think much more important and interesting topic.
What's that?
And that is your efforts over the last 40 years to achieve a consensus on what are the essential elements.
Well, before getting there, I want to follow up because I want to learn more about the steps you took with some colleagues.
I'm not interested in me. I'm interested in you.
Well, I feel the same way. but but you, together with, and I forget who the other cast of characters were, John Doherty, I remember, was one of the authors. And you worked, and I think the introduction to that paper made some reference to the difficulty in getting consensus. Now, you may have referred to DSM. And then you got experts together to make decisions about what medications to use under what conditions. Remember that? I forget what you called it.
It was called expert consensus. And what we did was send surveys to, say, instead of having 5 or 10 people decide, send surveys to 100 people.
Okay.
And I like the idea of the Supreme Court working this way. Instead of having the 9 people we have making decisions for the country, it would be nice to get the 1,000 constitutional lawyers together and tap their expert consensus opinion by doing a survey method. I think the major point is the smaller the number of people involved in decisions, the more likely they are to be heavily biased.
Right. So you did surveys and you got some kind of consensus, right?
Yeah, we did a statistical method. We established a priori what would be the method of analyzing the data. And we did use statistical methods to determine what would be first-line treatment, what would be second-line treatment, what might be unacceptable treatment. And the results were, in general, pretty good. And we included clinicians who were mostly medication-oriented. We included clinicians who were mostly psychotherapy-oriented. But for things like obsessive compulsive disorder, we got the clinicians pretty much agreeing that with mild problems, you should start with psychotherapy. With the more severe problems, you should have a combination of medication and psychotherapy. That even though they came from very different schools, when it came to discussing a concrete clinical situation, there was a good deal of agreement.
Right. And I kind of like that method. And in fact, we used this in a couple of studies that we did about psychological decisions. So I kind of like the notion of surveys of people. And let me just put a plug in. We just finished completing a survey. We have over 1,000 respondents. I don't know what percentage are clinicians and what percentage are researchers, because we haven't analyzed the data. But globally, we asked about the different principles of change. And we found a high degree of agreement that people said, yes, expectations and motivation are crucial, regardless of the orientation. Yes, the therapy relationship is important. Yes, increasing awareness or insight or metacognitive functioning is important. Yes, the corrective experience is core. So we haven't written that up yet, but you want to know about what I've been doing. Over 40 years ago, I published a paper, 1980, American Psychologist, and it was incredibly naive because basically I said, what we need in order to get agreement across different approaches to therapy, common principles, is we need to have a consensus meeting where we all get together. And that was very naive. We formed an organization, Society for the Exploration of Psychotherapy Integration. And that helped people to talk to each other from different orientations. And it was not an integration in a sense, it was a desegregation, which is what somebody called it, because we were talking to each other. We were learning from each other. We have the hallmark of the CEPI meetings is you go to the meeting to learn something from somebody else, which is outrageous because the typical goal is you go to the meeting to present your point of view to convince somebody else that she or he is wrong and that you're right. So at least we got the thing started, but we still don't have consensus. A lot of people have come up with their own integrative theories in this. So
tell us more about CEPI. I think because many people listening to this may want to join. Tell us about the size of the organization.
I don't know what the current membership is. It's under 1,000, so it's not that huge, and it's made up of people from different orientations. We have a newsletter, we have a website. So if you want to find out about it, you can go to Society for the Exploration of Psychotherapy Integration online, and you'll pull up the website and you'll see all the things that we do.
And this has been ongoing now for decades and successful in terms of capturing the attention of the people. And
originally my thought, and again, it was very, very naive, my thought was, okay, we're going to get agreement. And we had this whole thing about what the title should be. So it's SEPI, Society for the Exploration of Psychotherapy Integration. And my feeling was, and this was formed in the early 80s. So we're talking about close to 40, if not 40 years ago. My feeling is, after all these years, we should stop exploring and we should find something. I think we've been exploring too long, and I once suggested that we change the name to Society for the Evolution of Psychotherapy Integration.
How about the Society for Psychotherapy Integration?
How about getting rid of the society and just having integration? You know, rather than trying to do this, this should be a goal of the field as a whole rather than as one organization.
How far has that evolved through the exploration? How far along is it that?
It's raised the consciousness of people. And I think that's important. But the wheels of science grind very, very slowly. And there's documentation of that. Sociologists who have studied the development of science have shown that an idea can come out and be presented, and there's usually resistance to that idea. I think the idea of different orientations have something to offer. I think people accept that now. Certainly clinicians accept that. Because if they don't, they do it at their peril. Their patients just won't change. If you try to use one orientation and have your intervention based on the orientation rather than what is required in a given case. So I think SEPI has gotten the field to be more open.
What about the training programs?
It's evolving. And Louis Castengay at Penn State and Clara Hill have a bunch of conferences that they've held about each of these different principles of change over the years, of becoming aware, of corrective experience, and so on. We just completed a conference on clinical training. And there's some interesting contributions. It's going to be coming out in a book. I'm not quite sure if the publisher is Oxford University Press or American Psychological Association. But basically, some of the training proposals that I've seen are very, very exciting. And what they do is they focus on what process researchers call markers in a session, which are events in a session, where, say, a patient is, you get a sense that the alliance has problems, or you get a sense that the motivation is waning, or that their expectations are different from what the therapy is about. These indications in session can be operationalized. And in fact, there's been lots of research to show that you can train beginning therapists and even experienced therapists to learn how to deal with these situational markers more effectively. And the effectiveness is, one, based on research, and two, trans-theoretical. So motivation plays a part in all forms of therapy. The relationship plays a part in all forms of therapy. Expectations play a part in all forms of therapy. So this is, and this can be done with technology. of videos, which can give examples and models, and then also can be interactive, where the person who is learning can record and receive feedback. I see this as revolutionary in clinical training and supervision.
Marvin, can you estimate how many different psychology programs there are in the United States?
Gee, I don't know. It's an interesting question, but I don't know. I mean, there's the PhD programs, and then there's the professional PsyD programs. But I'm not quite sure.
So at least be a few hundred, right?
I don't know. If one of our watchers or listeners can let us know, we can mention that in our next podcast. It's a good question.
So I guess the practical question is that there's an enormous theoretical justification for integration. There's an enormous clinical justification for integration. Your surveys indicate that it's not that hard to figure out which things are common to all therapies. And Rosenzweig wrote about this eloquently 80 years ago. And so the practical question... 86 years ago. How do we go from what's the right thing to do? How do we get there from a situation in which we have a fairly fragmented, atomistic training program situation, which is also embedded so that many of the programs may have a financial or a guild or an emotional or an
that's an important question, and that's an important question. And then some of the issues that are involved are issues we've spoken about. But there is a field called dissemination science, which addresses that issue of how do you get research findings disseminated in places where they are used. My feeling is we're going to get consensus. It's not if, but it's when. And my feeling is sooner than better, because there are a lot of people that could use it. And instead of fighting amongst each other, I don't think most of the people who've gone into the mental health field have done it so that they can fight with their colleagues. I think the motivation was to help others. So I think we have to recapture that original motivation.
Are there associations of the training directors of various?
Yes, there are.
Would it make sense to do surveys of those people?
That's an interesting point. That's an interesting question. There are. Okay, well, these are all interesting questions, and we seem to be running out of time. So
see you next week.
Yeah, and we'll address some of these questions at some future podcast.
Yeah.
And thank you folks for watching and listening.
The idea of how to, maybe we could brainstorm next time, how to go from the wealth of knowledge and opinion to actually changing the world.
Okay.
And what would be mechanisms to try to get to the people who are actually doing the training to influence their behavior sooner rather than later.
Good point.
Okay. Bye-bye.
Talk to you then. Bye-bye.